yeah, this presentation will be focusing on, in fact, the clinical insights that have been provided by multi-segment kinetic foot models the last decades. Yeah. I don't have to introduce you that basically motion analysis occupies a quite critical role in podiatry practice, and this for diagnosis and the management of several foot and lower limb pathologies. Yeah. The thing is that associated to 2D videogoniometry, we have a number of problems. Yeah. And we do know those problems. Those are related to the parallax and the perspective that our cameras have with respect to the analyzed motion. Yeah. And also the complexity of the movement that we would like to study. Yeah. So basically we have an alternative nowadays, and this for more than 3-4 decades, I think, and that is the analysis through 3D motion analysis. And basically the approach that is most commonly used in 3D motion analysis is that we are modeling our body segments through the concept or the assumption of rigid body structures, yeah, and that's basically by attaching a number of markers, at least 3 non-collinear markers on each segment that we would like to analyze, and in order to have a good assessment of the 3D behavior. Yeah. Having said that, we have on top of that a number of challenges if we want to assess the foot, basically, because we have a lot of bones, 28 bones if we include the sesamoids. So there is some need of simplification, and that is needed. Yeah. So the last 3 decades, several methods have been proposed to improve the kinematic analysis of foot segments. And these have been termed in the literature multi-segment foot models. So those who are interested in that, have a look at it, and you will find under the mesh term or the simple keywords multi-segment foot models already a number of publications. And there remains considerable debate over how best to group foot bones into segments, and particularly in specific clinical contexts. Because a number of studies have illustrated that basically if we want to assess or adequately assess foot motion, there are basically only 2 bony segments in the foot that can be grasped correctly, and that is the first metatarsal and the calcaneus. Because these bones are relatively large, they provide ample space for marker placement. Yeah. They are superficial with easily palpable landmarks, and they have also relatively simple articulations with their proximal segments. Okay. So that's only for 2 segments of the foot, or 2 bones of the foot. Okay. So the definition of other segments within the foot requires decisions to be made regarding bone grouping. Yeah. And we have seen in the literature that this has been driven by a number of contexts and expertises, and we see, for example, that the foot has been modeled between 2 and 26 segments. Yeah. So having said that, a recent review reported by Leardini is at least highlighting that for those multi-segment foot models, there is a good basis to include those in clinical practice, because they have the potential, or at least contribute to our understanding and to our decision-making process. Yeah. So what our purpose was more than 10 years now ago is that basically if we are able to analyze the kinematic behavior of the foot over a number of foot segments, yeah, well, this is only a first step, because basically in our pathomechanical reasoning, we are much more interested to analyze the kinetic behavior of the foot segments. Yeah. And analyzing the kinetic behavior is for sure a more challenging task. Okay. So, and as I said, we started with tackling this task more than 10 years ago, and since about 5 years now, we are able to assess those joint kinetics within the foot in vivo, in our gait lab, in order to grasp better the function of the foot. The basic idea or approach that is used here is that we start from a multi-segment kinematic foot model, which you can see on your left side here on the left figure, where we will be segmenting the foot, and in this case it's 4 segments, by placing anatomical landmarks on a specific number of anatomical landmarks. On top of that, we are instrumenting our walkway, not only with a force plate, but also with a pressure plate, which is placed on top of the force plate. And by combining those two and synchronizing both equipments, basically the motion capture system and the force and pressure plate, we are able to combine that information and move forward towards an inverse dynamics approach, in which basically the segmentation provided by the multi-segment foot model is used for segmenting also the total ground traction forces occurring within each foot and each segment of the foot. And here we are using a proportionality scheme, which basically is looking or proportionally considering the vertical ground traction forces together with the mediolateral and anteroposterior ground traction forces. So from that perspective, we can for each segment analyze in time the center of pressure, and from there on also calculate the moment arms that for each respective joint is of application. And the first clinical output that is generated basically from those multi-segment kinetic modeling is the following. In this figure, you may see that we have basically, and I will just maybe put this on this side. So basically, you see the kinetics of 4 joints: the rear foot, the Chopard joint, which is the mid-tarsal joint, the Lisfranc joint or the tarsal metatarsal joint, and then you have the hallux or the toes. In red, you have basically the overall kinetic behavior of the foot if you consider it as a one rigid segment, as it used to be the case in the past. So if you look to the red graph, you will see that the foot has basically absorption capacity, which is in this side here the negative values, whereas the positive values represent the generation power in the foot. And so you can see on the right graph that basically your foot has considerable absorption capacity, but at least also considerably generation capacity, which is for walking about 3 watts per kilogram. So basically what we have observed by integrating a multi-segment approach is that our previous models, which considers the foot as one rigid model, that the power generation is considerably overestimated, basically by 15 to 20%. This is the origin of that overestimation comes from the fact that basically the plantar flexion angular velocity during propulsion is quite well overestimated. So this is one added value, clinical added value of our multi-segmental kinetic modeling here is that the overestimation has been revealed, first of all. Secondly, we see also, and this is for the first time, that we could clearly describe those kinetic behavior in those joints. What is that kinetic behavior in the distinct joints of the foot? For example, if you have a look to the rear foot, that absorption and generation capacity is considerably there. But on top of that, you see for the Chopard joint, something that we already knew theoretically, let's say, that is a quite important joint during dynamic activities. Well, we see that the Chopard joint has almost 0.5 watts kilogram absorption capacity during mid-stance and terminal stance, whereas in pre-swing, in the propulsive phase, we see a considerable power generation capacity, almost or approximately 1 watt per kilogram. On the other hand, for the Lisfranc joint, or the tarsal-metatarsal joint, we see also that this joint basically does not have absorption capacity in normal circumstances. Let's be clear, in asymptomatic people, that the Lisfranc joint is basically not having absorption capacity and has only generation capacity, or power generation. And then next to that, finally, you see in the green graph the kinetic behavior of the toes. And basically what is seen here is that the toes contribute considerably to the absorption of joint forces and the absorption of ground traction forces during mid-stance and terminal stance, and only participate to a short extent and a minimal extent to the propulsive phase in generating power. So other clinical viewpoints that we have had here also, and that we have published 2 years later in 2019, was basically the kinetic behavior of those foot joints during running. And we had a look to this, these joint kinetics during 2 specific running conditions. As you will see here in red, it is the running conditions when our athletes were running with the rear foot striking pattern. And in green, you see the results of the studies when those athletes were running, the same athletes were running with a midfoot or forefoot striking index. So basically what we saw here from the left to the right, you see again the rear foot, the Chopard joint, the Lisfranc, and then the toes. That basically we have considerable absorption, power absorption in the different segments of the foot. Okay, if you look at this, basically when you will be landing on the forefoot or the midfoot, your absorption in the ankle joint will be drastically higher. Okay? You end up with 10 watts per kilogram on power absorption, which is significantly different if you would land on your heel, because then your absorption is only about 5 to 7 watts per kilogram. Okay? Your power generation is the same for both conditions. At the level of the Chopard joint, you see the same behavior, basically, that if you land on the midfoot or forefoot, basically, your midfoot will be a mobile adapter and will absorb considerably power, okay, already between from 0 to 30 or 40% of the stance phase. Okay. Here, some remarkable observation for the Lisfranc joint, that the Lisfranc joint, as I said, during walking, we don't observe absorption at the Lisfranc joint, okay? Lisfranc joint is only generating power during walking. Here, we tend to see some discrete, it's not big, let's be clear, but we see a discrete power absorption capacity in the Lisfranc joint, but it remains very small, because those athletes were running here about 12 to 13 kilometers per hour barefoot, okay? Let's be clear. So as you can see, almost there is some absorption, but we saw also some heterogeneity throughout the athletes, but basically the Lisfranc joint has primarily generative capacity. And then for the toes, you see again, also during running, it has considerable power absorption, which goes up to about 2 to 3 watts per kilogram. Okay, and we do know that that power absorption capacity is critical at the level of the toes, because that will help in redistributing also the pressure underneath the metatarsal heads. And basically, if you have hallux limitus, hallux rigidus, or you have claw toes, rigid toes, all the deformities that we know associated to diabetes, for example, will basically, from a mechanical viewpoint, we will see that the power absorption will be critically lost at the level of the toes, and that's one of the mechanical phenomena which we have to bear in mind when we start looking at such kind of phenomena as illustrated here. So those are the different critical aspects. What we also did more recently, and a paper which we recently published in Clinical Orthopedics and Related Research, is that we are having a specific pathway or research pathway in the domain of osteoarthritis. And basically, we have always had the hypothesis that if patients have osteoarthritis in the ankle, for example, you will probably hypothesize that they will use some compensation strategies, for example, in the midfoot or in the forefoot or in the toes, somehow to compensate and maintain a physiological gait pattern. So this was one of our research questions in this paper also. So we recruited in our orthopedic unit here a control group and a patient population of 16 patients with isolated ankle osteoarthritis. Let's be clear, so isolated, all the other joints were physiologically normal. Didn't show signs of arthritis, of osteoarthritis, okay? And we had a look to their kinetics again, okay? And look and see if this research question could be rejected or should be accepted. So on the top here you see the first of all the results of the ankle, and you see on the left side the internal moment in the sagittal plane. Then in the middle you have the angular velocity, and then you have the joint power. So what we observed here is in this study is that basically at the ankle peak internal moment, plantar flexion moment, was significantly different. Okay, so the loading of the joint was significantly lower throughout the propulsive phase. The same at the level of the angular velocity, so the range of motion, the flexion range of motion was reduced. It's obvious because we have osteoarthritis, and associated to that, you can imagine that you have some stiffness in that ankle and the soft tissues around. So we saw also that the angular velocity, the peak plantar flexion angular velocity, was reduced dramatically. And as a consequence, you may observe here that the power absorption and the power generation was critically decreased in the ankle in that population. So the idea was now to look at the other joints. Are those joints capable, or is it a strategy to increase or compensate for that loss of power absorption, for example, in the other joints? Okay, and basically what we saw is that also the internal peak plantar flexion moment was reduced at the Chopard joint. The angular velocity during propulsion was also reduced. And we saw in those patients that basically the power generation from the midfoot was also reduced. For the Lisfranc and the toes, we didn't observe any different or statistically different changes here. So basically, our hypothesis, we had to reject it basically, because we started from the principle that, well, the pattern that we are seeing here is a antalgic gait pattern where co-contraction potentially and stiffness is built within the full lower limb and in the foot specifically. in order to compensate for pain, yeah. And we don't see other types of compensation strategies like as we suggested in the beginning. Okay. On the other hand, regarding another pathology which is commonly seen in our podiatry practice, I think, is tibialis posterior dysfunction. Yeah. And here also in our orthopedic unit, we have recruited next to a control group. We also recruited a group of patients with tibialis posterior dysfunction stage 2, as well as a small cohort of stage 3. Yeah. The distinction between the two stages here lies in the fact that in stage 2 you have basically a tendinitis, obviously, with weakness of the muscle or the tendon, and associated to that some starting malalignment of the hindfoot. Yeah. In stage 3, you start to see also arthritis at a number of articulations, and in stage 4 you would see then some rigidity and a stiff pes plano valgus, let's call it like that, okay, for the time being. Okay. So we compared the kinetic behavior of those foot joints, okay, across those three groups. Again, what you can see here on the top is the ankle joint, and you have the internal moment on the left again, the angular velocity in the middle, and then the joint power. So if you look for those three groups now, you have here the control group, then the PTD, and the legend for the stage 2 group. We saw that basically the peak plantar flexion moment was critically decreased in those two patient groups. Yeah. Which was already a first sign, okay, of potentially weakness. Yeah. Followed by that, we saw also that at the ankle, yeah, we saw that the peak plantar flexion velocity was drastically decreased, yeah, and that as a consequence also, yeah, we saw a dramatic decrease of power generation in that joint. Okay. So our hypothesis was also that we were very interested to look at the Chopard joint, basically, because as we know, the tibialis posterior tendon has his distal insertion at the navicular and other small branches further on in the foot. Yeah. So we would expect also changes in the midfoot. Yeah. And basically, yes, indeed, we saw that the loading of the midfoot was statistically lower, okay, in the midfoot. Yeah. So the peak plantar flexion or the internal peak plantar flexion moment was reduced in both patient groups. Yeah. Also, the peak plantar flexion velocity of that joint was reduced, and what we then saw here is that most dramatically is that the power absorption in the Chopard joint was much greater. Okay. So in real numbers or in absolute values, you would see that almost the power absorption in the midfoot in presence of tibialis posterior dysfunction was twice as high as in normal circumstances. So you see clearly here an instability within the midfoot in those joints on the level of the kinetics. And additionally to that, or associated to that, we saw that basically the power generation of that joint, of the midfoot joint, was reduced. Yeah? So we saw an increased absorption and a reduced, and a critically reduced power generation in that joint. Okay? So for us, this is quite clinical relevant. Yeah? Because you will probably know that, and you see some other numbers here, yeah, but basically if we look to conservative treatments for stage 2 tibialis posterior dysfunction, we are often looking at foot orthotics, footwear, eventually braces, yeah, physiotherapy, yeah. So our approach here is that we should target dramatically the midfoot kinetics. and try to control that increased or reduce that increased power absorption in the midfoot, okay? Because then we potentially might be efficacious from a mechanical viewpoint. Yeah. On the other hand, and that's basically one of our most critical things that we are looking at here, is that basically after 6 or 9 months of conservative treatments, if our patients are not to a satisfactory level treated, with conservative treatments, basically the guideline says that you should go for some surgery in order to avoid that those patients are moving towards considerable malalignment in their foot. Yeah. So our suggestion here is that the surgical interventions, such as medial shift osteotomies of the calcaneus or tendon repairs, repair of the plantar ligament, etc., should be guided by our gait analysis. Okay? Because we see that in some patients we have a considerable increase of power absorption, and we believe that even with a number of osteotomies and tendon repair, even we will not be satisfied. Because we have too much instability, and that we are putting forward the hypothesis that in a number of small cases, probably we need to think of an arthrodesis, for example, of the talonavicular joint, because we have also observed that those patients with PTDD or tibialis posterior dysfunction show obesity, or at least have an increased BMI, which is again from a rehabilitation perspective a critical thing.
Kevin, 3 minutes to finish. The
last information.
Okay, thank you.
Okay, so finally we had also a clinical output regarding the diabetic foot, because we are looking at or trying to unraveling joint destruction mechanisms in the diabetic foot. And just to summarize here, we have 3 groups. We have a control group, and then we have recruited a group with diabetic group with neuropathy and without neuropathy. And also here we saw that at the ankle joint, the peak plantar flexion velocity was critically reduced in those 2 patient groups. But more critically, at the Chopard joint, we saw that the power generation and the positive work was critically reduced in those 2 patients. So this shows that those people are having stiffness in their feet. And for us, we are putting forward that we will have a new insight here for unraveling joint destruction mechanisms in the diabetic foot, as we know that those people are developing foot deformities such as, or others like Charcot arthropathy. And with this, I would like to thank you all and